Hi everyone. So welcome to our third session of this 100 days to 100 percentile series. So we started this off primarily based on two things. One, we wanted to provide as many Nelson updates, that is the 22nd edition Nelson updates, as possible. We did do a series after the 21st edition based videos came out. We did do the allied test and discussion, which is based on the 22nd edition only. All those explanations which we have given, that is also based on the 22nd edition. But coming to again, we wanted to double down on the previously asked topics. So as you know, there is a serious dearth of previously repeated asked topics as far as NEET SS and INSS pediatrics is concerned. So we've been trying to dig into that, especially the NEET SS, because the NEET SS is upcoming, and we are basing our this series as well as our mini test based on those previous year topics. So now I wanted to kind of finish off the PEDS ROMAT portion of the previously asked 2023 paper. That was the last paper. 2024, obviously we are going to have it in the upcoming March session. So we only had four questions. They were from the usual suspects only, no weird questions, nothing from, in fact, no question was asked from primary immunodeficiency disorders, no autoinflammatory syndromes. The primary suspects that are your juvenile idiopathic arthritis, juvenile dermatomyositis, and your Kawasaki disease, HSP. These were the only areas which were focused upon, which are obviously important. Even somebody as a resident who's preparing for his MD exit also, these are the usual topics that we read. Neonatal SLE, childhood SLE was not asked. So first question was on HSP. Obviously, it's a easy question, more or less. Low grade fever was there, crampy abdominal pain, knee swelling and knee arthritis in general, and petechial rash. So these, and also kidney biopsy showed proliferative glomerulonephritis. So you have a tetrad, right? You have your palpable purpura, which is your synconon, that is your essential condition for diagnosis. Then you have three, out of which you have four conditions, you have four characteristics, out of which you need to. We'll come to that. We'll come to the diagnostic criteria. But in general, there are four organs that are involved: the skin, the GI tract, the kidney, and the joint. So we have all four given here. However, there are differentials. The options were close, and that also we will look to about how you should differentiate between the options. So options were HSP, that is IgA vasculitis, Kawasaki disease, infantile hemorrhagic edema, as well as meningococcemia, right? So HSP is the most common vasculitis. There is a confusion between IgA vasculitis and Kawasaki disease. Overall, across the world, definitely it is Henoch-Schonlein purpura. So if direct question is asked, go with Henoch-Schonlein purpura. So it's basically a leukocytoclastic vasculitis mediated by IgA. IgA deposition occurs if it is asked, it is mainly IgA1 that is deposited here, and it deposits in all of these four organs that we discussed. And most of this, the age group is school going children, around 5 to 7 year age group, and predominantly occurs in your winter and spring. There is a temporal association that is commonly seen with URIs, but again, it's not as correlating as something like a reactive arthritis or something like a acute rheumatic fever. It's not so well correlated, but there is certain correlation with your group A beta hemolytic strep predominantly, as well as your mycoplasma and staph also. So then we come to biopsies. As you saw, the question also had this particular line that kidney biopsy was done, which showed proliferative glomerulonephritis. In fact, kidney biopsy is not performed usually because most of these glomerulonephritis is self-resolving, and that has a pretty good prognosis. But yeah, if you do not have if the proteinuria is severe, or if the child is in AKI, then definitely you have to go for a biopsy. And the main typical finding in biopsy is actually the IgA predominant deposition, which is not given in the stem of the question here. Although, but that is what usually differentiates it. Like in general, endocapillary proliferative glomerulonephritis is something that can happen in any vasculitis, be it infective vasculitis, SLE, be it any primary vasculitis, small vessel vasculitis, anything can have this proliferative glomerulonephritis. But when it comes to this pure IgA deposition without IgG, IgM deposition, without much complement deposition, there is complement deposition here as well, but it's predominantly IgA that is there. So that is quite specific for your renal biopsy findings in your IgA vasculitis. Skin biopsy, again, that is not very specific to IgA vasculitis, but because you have these palpable purpura at your characteristic sites in your dependent areas, skin biopsy is a very good modality to kind of add a supportive evidence to your diagnosis showing leukocytoclastic vasculitis in your dermal capillaries. And as is most leukocytoclastic vasculitis, it's usually neutrophilic and monocytic infiltrate that is there. So this is the classical image of your typical palpable purpura in the lower limb. Nobody's going to forget this. We've been reading this through MBBS. So apart from that, skin biopsy. So here it's usually IgA deposition, but even if you do not, even if it is not given, just the palpable purpura, and if somebody is showing these Ig deposits, as you can see, these fluorescein deposits that are there, it's most likely an IgA vasculitis that they are trying to tell you. So clinical manifestations, which are obviously focused upon in this question, skin, mainly it is rash, palpable purpura. It can be multiple forms. It can be, it can be macular rash, it can be petechial rash, it can be ecchymotic rash. Sometimes it can be quite large as well. And if you have an increased age group, something like a 10-year-old or something like a teenage age group, it can also present as hemorrhagic blisters as well. So that also can be seen sometimes. So this you remember why I'm focusing upon. So the blisters can be seen in your IgA vasculitis. So musculoskeletal wise, again, it is non-erosive arthritis that is there, self-limited, oligoarticular, lower limb predominant, ankles and knees are mainly involved. Again, this is also important that knees and ankles are involved. This is also crucial to differentiate from a particular other differential diagnosis that are there. Coming to GI, main thing that is important to remember, lot of times given as an important clue in your MCQ is your intersusception. So it can present without intersusception, it can present just like a mesenteric vasculitis with abdominal pain, diarrhea, vomiting, etc. But if ever there is a intersusception in a child, in a school-going child with arthritis, with petechial purpura, then again IgA vasculitis is your primary differential. Renal, I told you about, it is not very specific. Endocapillary proliferative glomerulonephritis occurs, both nephritic and nephrotic syndrome features will occur here. Neurological is not very common, but at the same time, because of the renal involvement as well as directly because of the vasculitic involvement, because of both of these involvement, there can be hypertension, there can be press features as well as intracerebral hemorrhage, etc. can occur. And because of the associated vasculitis, vasculopathy, you can have neuropathies as well. So rash, as I was telling you, hallmark, it is the sine qua non for diagnosis that this has to be there for you to make a diagnosis with confidence. And even in the diagnostic criteria, as we'll see, this has to be there. So bulle and ulcerations, especially as the age increases, symmetric, lower limb predominant, extensor aspect predominant rash is the rule, and it usually lasts for around 3 to 10 days and resolves. And subcutaneous edema is also common. So this was one of the differential that was there another option that was there, that is infantile hemorrhagic edema. So here also edema occurs, but there are certain other pointers that can differentiate between an IgA vasculitis and an infantile hemorrhagic edema. So this is the diagnostic criteria I was telling you about. It is the Euler press criteria. So here you have the palpable purpura, which is needed in the absence of coagulopathy, thrombocytopenia. Of course, you have to rule out other causes of this palpable purpura, and along with that, 1 out of 4. In this, 3 are the systemic manifestations, that is your GI manifestation, arthritis manifestation, and your renal involvement in the form of proteinuria, hematuria, or CAS. Along with this, you have one biopsy finding. Mainly, you should have IgA deposition there. So this is your classification criteria, which is important. May not be asked because this is a classification criteria. It's not exactly something that is the gold standard for diagnosing a patient, but this helps you in making a diagnosis, as is the case in this MCQ as well. So these are your differentials that you should rule out whenever you look for palpable purpura. Firstly, especially when you have associated nephritis, PSGN, you should rule out all your nephritic syndrome etiologies. You should rule out SLE. You should rule out other vasculitis, primary or secondary vasculitis. All of these you should rule out. But your 2 main differentials that were given in your MCQ are your infantile acute hemorrhagic edema, that was given one, and the other was meningococcemia, right? So AHE or infantile acute hemorrhagic edema, you have the age group that is different. Younger age, obviously, in AHE, it is infantile age group. Then you have edema, which is tender. In IgA vasculitis, as you saw, edema can be there, subcutaneous edema can be there, but it's not so tender, and also it's not the predominant manifestation. The predominant skin manifestation in IgA vasculitis is palpable purpura, while here it is this tender edema, and also here it's the trunk is usually spared. In IgA vasculitis, the trunk is also involved along with the lower limb, but here usually the trunk is spared, and also the size of the lesions is much larger in your AHE when compared to IgA vasculitis. Also, the other joint involvement, for instance, the renal involvement, GI involvement, that is very, very less in your AHE when compared to that. and also the IgA deposition. So whatever you are thinking that is somewhat specific to IgA vasculitis, all of that will not be there. While the tender edema that is there, that is more specific for your AHE and also the location of the lesion. So these are what are the main differentiating features between AHE and your IgA vasculitis. So this is something that is obviously given in your Nelson as well as asked in your NEET tests. So don't be surprised if they actually give a case scenario of AHE and ask you this as a answer being for the next question, right? So meningococcemia, again, another important differential. They can give you meningococcemia from the infectious disease chapter, and they can give you IgA vasculitis as the option. That also can happen. The main obvious differentiator is your systemic signs, right? In your meningococcemia, you will have fever, which is higher grade, persistent fever, shock like symptoms are possible. Then it's much more acute, hyperacute manifestation will be there. All of that is there. Basically all of this thing that I was talking about, as well as your so shock, this, all of this is kind of more in your meningococcemia, while your typical findings, that is your nephritis, more in your IgA vasculitis, renal involvement, nephritis, arthritis, all of this is more in your IgA vasculitis, and also this distribution of the skin rash. In IgA vasculitis, it is symmetrical, lower limb predominant, while meningococcemia, it's not especially involving the lower limbs. They can give you an image where the lower limb is involved because it can, but it's not so as specific as it is in IgA vasculitis. So blood culture, coagulation profile, also DIC can occur in meningococcemia. So everything PTA, PTT, thrombin time, everything will be prolonged there. Urine analysis, more importantly in your IgA vasculitis, will show hematuria, proteinuria, complement activation. When will it occur? When there is immune complexes formation in a very high degree. So that very high degree immune complex formation occurs in your meningococcemia. In IgA vasculitis also it will occur, but not to the same degree. So complement levels will be much lower in your meningococcemia. Skin biopsy, we know in meningococcemia, there can be DIC, so you may find necrosis, thrombosis, etc. While here it is IgA predominant leukocytoclastic vasculitis. Treatment also it is, IV antibiotics, etc. there, while here it is supportive care and steroids. So we're not going to the treatment of IgA vasculitis, but that is how you can differentiate as well. So next question was about, so 18-month-old child presenting with systemic onset JIA, and now he or she has high spiking fever, hepatosplenomegaly, lymphadenopathy, purpura, and encephalopathy. Laboratory investigations show thrombocytopenia, hypofibrinogenemia with transaminitis and low ESR. So this is again a more or less straightforward question. So they might ask you with they have given a diagnosis here directly that it is a patient of Sogia, but they might even give you a patient who has something like a salmon rash with transaminitis with classical joint pain, deforming wrists. They can give you that and then say that this is the current presentation. What is the differential? Whatever case it is, the main differences, the main confusion might be between the flare of systemic disease and HLH or MAST. So in between these two, the main differentiator is the low ESR that we will see. So characteristic differences between various juvenile idiopathic arthritis is not we need to focus upon in this particular question because they've directly given. But obviously oligoarthritis will be less than 5, polyarthritis will be 5 or more. Psoriatic arthritis will have classic psoriasis findings in your skin, in your nails, nail pitting will be there, onycholysis will be there, dactylitis, family history can be there. In enthesitis related arthritis, there will be predominant inflammatory lower backache. It's something like your spondyloarthropathy that you might have read in your medicine. So it's something like your predominant inflammatory lower backache predominant complaints. So that is what is the differences between your other JIA versus systemic JIA. Systemic JIA, as the name says, it has systemic involvement, it has transaminitis, serositis, skin rash. Skin rash is very important. So it is evanescent erythematous violaceous rash that's seen on the trunk, also called as salmon rash. So that is an important finding that can differentiate, and obviously hepatosplenomegaly, lymphadenopathy, etc. So if you see in the stem, a lot of things can be flare of the systemic disease as well. It's, as you can see, high spiking fever can be there in your Sogia, lymphadenopathy, hepatosplenomegaly can be there in your Sogia, purpura maybe skin rash mimicking the purpura can be there. Encephalopathy is something that is not usually there in your systemic GIA unless there is very high grade fever or something. So that also is somewhat confusing. But when you see cytopenia is a very good differentiator, because usually systemic onset GIA will have high grade leukocytosis, high degree of thrombocytosis, especially when there is flare of the disease. So here cytopenia being there is definitely against flare of disease. Hypofibrinogenemia, not really kind of something that changes in your flare of systemic disease, but ESR definitely will increase in your flare of systemic disease, while ESR decreases in your HLH. So why does HLH ESR decrease? That also we'll see. So as systemic onset GIA, arthritis is one or more joints. So you can just remember this as 1, 2, 3, 4, right? So one or more joints for 2 or more weeks, and this has at least 3 days of daily quotidian fever. So quotidian fever is high grade fever approximately around 39 degrees or more, and it should be once daily, and every day it should return to normal. So this is how the quotidian fever graph is represented, and this is 39 degrees Celsius, right? So this is quotidian fever, and that should be there for at least 3 days, and it should have 1 out of 4 of these other manifestations, which include serositis, hepatosplenomegaly, lymphadenopathy, and your skin rash that is there. So you can remember it as 1, 2, 3, 4. So once you have that, then other characteristic features of your SOGIA are your 1:1 female to male ratio. That is different in others. Oligoarticular, polyarticular, it is more female predominant. Psoriatic enthesitis related, it is male predominant, but in SOGIA, it is 1:1 ratio. Arthritis is usually polyarticular with deformities, especially in your wrists and ankles. Extraarticular manifestations I told you about, and lab investigations. Very importantly, there is cytosis here with increased ESR, increased CRP, of course, but also in HLH, which is a common complication, then there is a difference. So HLH, hemophagolymphohistiocytosis or macrophage activation syndrome. So basically, macrophage activation syndrome is what is secondary HLH in rheumatoid diseases, right? So HLH is basically your lymphohistiocytes kind of malfunctioning, and they causing various manifestations, that there can be cytopenias. Basically, they increase in function, right? So increase in function, they eat up cells as well as they produce cytokines which cause various manifestations. So that is what is happening in your MAS or HLH. And when it happens, when HLH happens in your rheumatoid diseases, it is secondary HLH, and that secondary HLH in rheumatoid diseases is called macrophage activation syndrome. So as I told you, it's a cytokine storm as well as increased cell activity, that is increased phagocytosis also occurs. So both of these will cause cytosis. Increased phagocytosis will obviously cause cytopenias, while your increased cytokine storm will cause other manifestations like your increased transaminitis. It will cause serositis. It can cause decreased fibrinogen leading to decreased ESR, etc. Right? So immune cells communicate with each other usually via various cytokines, and also directly also. For example, some NK T cells will usually eat up the macrophages or kill the macrophages and keep those macrophages in check. When these NK T cells malfunction, then two things will happen. These NK T cells will directly release various cytokines, as well as they'll not be killing these macrophages, and these macrophages will increase and they'll cause various phagocytosis, increased phagocytosis as well. So this is what I was telling you about. These are your cytotoxic T cells or NK cells. So this is keeping a control on your macrophage. So once this cytotoxic T cell NK cell malfunctions, one is it increases cytokines, and other also this negative effect will go, and because of that this macrophage will also increase, and this will cause increased phagocytosis, and increased phagocytosis will lead to cytopenia. So these are your two main modalities: cytokine secretion and increased phagocytosis, through which various malfunctioning, various pathogenesis of mass occurs. So excess activation, multiplication of macrophages as well as cytotoxic T cells. Cytotoxic T cells can be activated in the sense of increased cytokine release, but their function of suppressing the macrophages, that will again be malfunctioning, and that will not occur, leading to cytokine storm and massive inflammation. So this can occur in various rheumatological conditions, infections, etc., etc., and that will cause various manifestations, including fever, cytopenias, hepatosplenomegaly, lymphadenopathy, etc. So yeah, so macrophages will be overly activated, start phagocytosing normal blood cells as well, and destroy those cells, leading to severe cytopenia. So how can this occur? One thing is your disease that is causing this abnormal malfunctioning, but it can also be at a more preliminary level, for example genetic level. So whenever it is at the level of genetics, then that is when we call it as usually primary HLH. So now we are talking about mass, where here it is the abnormality, there is the abnormality, that is high levels of IL-6 cytokine because of the disease activity, and functional defective cytotoxicity that can also be caused by disease. This is your second layer. First layer was genetics, then you have the second layer, and third layer can be a trigger. This is very, very common. Sometimes without a trigger, without an infection also, a mass patient, a mass child can go directly into HLH, but a lot of times, at least 50% of the cases in most of our case series reports, we see that viral infection is the most common trigger for mass in a Sogia patient, right? So we have these three levels at which triggers can occur, leading to macrophage activation and cytokine storm. So this is your genetic abnormalities. Just at least perforin gene is important to remember. Otherwise, also there can be varied levels at the level of genetics that can occur. Otherwise, there can be flare of genetic disease. Drugs can cause this in viral infections, especially most commonly EBV. All of that can also cause these triggering at various levels. So high onset fever, high grade fever, acute onset, lymphadenopathy, hepatosplenomegaly, and also, as you saw in our index case, encephalopathy is also a good indicator. It's not that encephalopathy will occur in almost all patients, but it's a very good indicator. For example, a mass patient, otherwise usually stable with respect to CNS, now precipitating encephalopathy, you should go towards a possible diagnosis of mass. Lab evaluation, as I told you, cytopenias, transaminitis, increased certain markers will be there, which are very, very important clues, especially your increased ferritin. Apart from that, also there can be hypertriglyceridemia, hypofibrinogenemia. As I told you, fibrinogen will decrease, ESR will decrease, increased transaminitis, AST, ALT, as well as increased LDH as well. So these are very important clues. And also, as I told you, fibrin will be destroyed, fibrin degradation products will increase, as well as increased APTT and PT. So because fibrin is not there, the RBCs cannot stick to each other. That is what is erythrocyte sedimentation rate, right? So the RBCs should stick to each other because of fibrin, and then they settle down, and that will lead to increased ESR. So here fibrin is not there, RBCs are not able to stick to each other, and ESR falls, or cannot, the erythrocytes cannot sediment with each other. So this is how the patient will present, both clinically as well as lab. Both of these are very, very important to be done to arrive at a diagnosis of mass, and especially serum ferritin. Serum ferritin being very high with cytopenias, with transaminitis, and other, markers like LDH being high are very important clues. But all of this can rarely occur in your direct disease as well. One thing that can directly differentiate, one is the cytopenias, because it's directly an opposite change, right? Cytosis occurs in your disease activity while cytopenia occurs in your mass. And the other thing is your ESR. ESR increases in your disease activity, decreases in your mass. Also, we have these lab tests which are usually not done, but they're important as far as your diagnostic criteria are concerned. One is soluble CD163 levels and IL-2 receptor alpha levels. Both of these are basically markers of your increased macrophage activation as well as your T cell dysfunction that is there. So this is your criteria. Again, these values you need not remember, but at least from a clinical point of view, and also like the question as you saw, you need to understand what are the basic changes that occur. Serum ferritin, the most important one. This at least you may need to remember, but otherwise you can ignore the numbers that are there. Thrombocytopenia, transaminitis, hypertriglyceridemia, and hypofibrinogenemia leading to decreased ESR. These are the main changes that occur in your mass. So these are your, again, summarizing CNS dysfunction. Don't forget, and among this there is decreased ESR, and also there can be other changes that are not so specific, but again soft markers. They can act as hyponatremia and hypoalbuminemia as well, and increased CD163 staining. As I told you, increased macrophages will occur, and this can kind of show in the form of increased CD163 staining. Bone marrow is very helpful because these macrophages will be phagocytosing those cells that are there, your bone marrow cells, and that can easily be seen in your bone marrow aspirate. Treatment, again, it's not very important. The main starting treatment is your high dose corticosteroids at around 10 mg per meter square. Dexamethasone is given. Along with that, there is anakinra, cyclosporin, IVIG is also given. All of these are established treatment. In very, very difficult cases, etoposide is usually used in refractory mass treatment. Next, we come to JDM. So JDM, you had two questions in 2023. One is about the antibodies that are there. So this one I have kept because this was on the slightly atypical side. But otherwise, there was another question where a child's image was given. Image was given showing Gower sign as well as your Gotran's papule. So that was a much simpler question. The we didn't get the exact recall because it was so simple that the exam goer didn't remember the exact framing also. So that was fairly simple, but this was slightly atypical where your antibodies, your muscle myositis specific antibodies were asked, right? So clinical manifestation, again, fairly simple dermatomyositis, right? So you have muscle weakness, mainly symmetric proximal muscle weakness, as well as skin rash. These are your main two complaints. Skin lesions are important to remember. Multiple types of skin lesions can occur. There can be a facial rash that resembles facial malar rash that very closely resembles SLE. So there also it is photosensitive. Here also it is photosensitive. But the main difference comes in your nasolabial fold. So nasolabial fold sparing, if it is there, then it is a sign of SLE, while if it is involved, then it is seen in juvenile dermatomyositis. Then, apart from this, you have your two pathognomic signs, your heliotrope rash of the eyelids and Gotran's papules, both of which images are important that we will see. And also, there are multiple other changes. Calcinosis is important, lipodystrophy is important. Both of these occur more in your children when compared to the adult counterpart of this disease. Then there can be Raynaud's, there can be arthritis, arthralgia. Of course, there is a possibility, and also there are ulcerations. So one of that was ulcerations, anti-MDA5 especially. Okay, ILD was given here, but even if they ask you next time, anti-MDA5, two important things that you should remember that are associated with these antibodies are ILD as well as skin ulcers that are there. Then calcinosis also, it is associated with anti-MJ or NXP2, calcinosis contractures, all of that is there, and ILD as well as your various nail fold capillary changes, all of that also is there. Muscle weakness, proximal muscle weakness, symmetric lower limb followed by upper limb. That is the main description of the muscle weakness. Then yeah, this is the diagnostic criteria. Again, this is a diagnostic, not a classic classification criteria like we saw in your IG vasculitis. But here it is much more important because it can help you to kind of base your workup, right? So whenever you have a possible juvenile dermatomyositis case, this is what you will look at initially, at least the muscle enzymes, EMG, and your muscle biopsy is how you will go. If your muscle enzymes are elevated, if you have classic skin and muscle findings, there's no need to go ahead with your muscle biopsy. Muscle biopsy is mainly to kind of zero in on a diagnosis when you don't have a classic clinical diagnosis. Otherwise, you will not do the muscle biopsy. EMG is always good to be done. You have fibrillations, you have short duration, short amplitude, polyphasic muscle action potentials is how you usually see, right? So this is your classic facial rash where you have involvement of your nasolabial fold. So this nasolabial fold is involved in your juvenile dermatomyositis. And also here you have your heliotrope rash. It's a violaceous discoloration, and a lot of times it is involved with edema as well. So yeah, another one important thing in your muscle weakness is your Gower sign. So Gower sign, we usually associate and study it with Duchenne muscular dystrophy and our muscular dystrophies, right? But here also, if this is especially important if a clinical case is given and Gower sign is said to be positive, option is given as your DMD as well as dermatomyositis. Don't jump directly to DMD. Yes, it is more specific for DMD because in dermatomyositis, usually till the time Gower sign manifests, till that time there is already skin rash, already patient would have many other symptoms like your ulcers, contractures, all of that, and a lot of times that itself can give you a diagnosis. In your Duchenne muscle dystrophy, there only be one manifestation, that is your muscle weakness with Gower sign. So that is why Gower sign has been associated with DMD more, but in myopathy, that is your inflammatory myopathy also, this can be there, right? So this is your Gotran's papule. So this is another thing. If you have proper papules, obviously you can directly diagnose as your juvenile dermatomyositis, but sometimes it can just be a macular rash. So in those macular rash conditions, there'll be a certain conundrum whether it is an SLE-like rash or your dermatomyositis rash. So here, whenever you have your knuckle involvement, so whenever you have knuckles involved, then it is dermatomyositis, while if it is paired, then it is SLE. So these are two important clues. Here it is nasolabial fold that you use, if it is involved or not. If it is involved, it is dermatomyositis. If it is paired, it is SLE. So this is one important clue that you can differentiate, because one of the questions that I was telling about, that was an image based question. So I'm slightly focusing more on the images, because they might just as well give you just an image and ask you a spot diagnosis. That can also happen. So in that case, you can use these clues to zero in on the diagnosis. So these are the pictures. Heliotrope rash associated with periorbital edema. A lot of times, Gotter's papules that we were discussing, if they're not papules, if they're just macular rash, then you call it as Gotter's rash. Then there can be malar rash, rash on extensor surfaces, V sign, that is involvement of the anterior aspect of the neck in the form of a V, that is V sign. Shawl sign is as in the areas where you put a shawl, right? If you have your anterior chest as well as your posterior area that is involved, that is this area, then that is shawl sign. And you have calcinosis as well, that is associated with anti-NXP2 or MJ. These are the same antibody, it has two names, NXP2 and MJ. So apart from these basic diagnostic modalities that we saw EMG, we saw muscle enzymes and your clinical evaluation. After that, we do X-rays to rule out calcinosis. Calcinosis is something that is seen a lot in your juvenile dermatomyositis, but not so much in your adult. So always get an X-ray done of the whole body. Then you have MRI. MRI is a very easy, it's difficult to get, but it's a very important clue to diagnose whether the disease in its active state or the muscle fibers have fatty infiltration and have atrophied, and now there's no active disease that is going on. So because to understand the context, juvenile dermatomyositis is not continuously progressing disease. Something like SLE, the disease will keep progressing until and unless you intervene and immunosuppress the patient and stop the disease progression. JDM, juvenile dermatomyositis, is not like that. The disease will by itself go into a self-resolving stage and sometimes will never even recur. So in those cases, there'll just be some fibrofatty infiltration that has come into the muscle mass, and that will not go, right? So that versus an active disease, it's important to differentiate. If it is just fibrofatty infiltration, you would just kind of follow up the patient and then just give him some supplements, give him physiotherapy and then follow up the patient. But if there is active disease, you will immunosuppress. So it's very important to differentiate between disease activity and disease damage in your juvenile dermatomyositis, and MRI helps in that a lot. So T1 images are usually used to see anatomy and chronic changes, while your T2 images, or we also call it STIR images, that is your short tau inversion recovery. It's one of the modalities to see inflammation. It's one of the modalities that accentuates the water that is there in the muscle, and it increases the hyperintensity whenever there is water, right? So this is used to see activity and inflammation. So these are the two modalities that you use, mainly T2 or T2 stir is that is what you should remember, right? So abnormal MRI findings may be there even if muscle derived enzymes are normal. As I told you, sometimes the disease will be quiescent, there will not be any active muscle damage that is going on, so muscle enzymes will be normal, but MRI will be abnormal. Contrast swallow not usually done unless there is a difficulty in swallowing because of muscle dysfunction, muscle weakness, then you can do that. So these are the various other set of images. Calcification, very important, as you can see here. These are various calcification that you can see in your X-ray, in your radiographs, hence it's very important. MRI, again, main thing that you see is your hyperintensities in your T2 stir images. Muscle biopsy, not very important, not done in all cases. A lot of times what you do is get your MRI done, you see which area is active muscle disease there, and also in a context of you not having a specific diagnosis, you feel that it may be dermatomyositis, but again you're not sure if it is infectious myositis, if it is some rhabdomyolysis going on, if it is some metabolic myopathy going on, if it is some muscle dystrophy. In those particular scenarios, muscle biopsy helps a lot. You get the muscle MRI done, you see which area is involved, that particular muscle you will take in biopsy. And usually in dermatomyositis, you see perivascular and perivascular inflammatory infiltrate that is there. So now finally coming to antibodies, the question that was asked, you have two major groups of antibodies. One is the muscle myositis associated antibodies, which are not really specific to dermatomyositis, but they're also seen. They're mostly seen in overlap syndromes. For example, PMSCL. This is seen in polymyositis. PMSCL stands for polymyositis scleroderma, right? So this basically is seen in myositis scleroderma overlap. So in these conditions, it's not that there is only myositis that is there. There could be skin thickening, there will be contractures to a large extent, there will be possible lung disease, all of that will be there, and hence it's not a specific antibody, it's a myositis associated antibody. Similarly, you have Smith, SSA, SSB, all of these, as you know, will be seen in SLE, will be seen in other connective tissue disorders. These are myositis associated antibodies. Myositis specific, you mainly have four that you need to remember, the four antibodies that were given in your question. So we have P155, P140, this is there, then MJ, this is also called NXP2, and MDA5, and your Jo1. So these are your three main antibodies. P155, P140 is also called TIF1 gamma. So these are your four main antibodies and your various names also. So among these, when it is TIF1 gamma, it is usually not a severe disease. It's your classic dermatomyositis, and also apart from this, MI2 is also there. I think that is missed out. Yeah, so MI2 antibody is also there. So among this, mainly you should remember that if it is MI2, it's not a very severe disease. It's your classic dermatomyositis, which we've been talking about. There's not much of contractures. There's no calcinosis. There is no interstitial lung disease. There's no ulcers. It's just your Gauton's papule, your heliotrope rash, and your myositis, muscle weakness that will be there. When there is P155, P140, then you will have increased ulceration, increased photosensitive rashes, lipodystrophy. These are your classic manifestations. Then when you have MDA5, there will be ulcers, and your ILD. These are your two other classical manifestations. And you have NXP2 MJ. Then you have contractures, calcinosis, cramps, muscle atrophy, and dysphonia. So this is what is given in your Nelson. There is a much higher list, but at least this much you should know, because this is given in your Nelson. Especially calcinosis and your ulcers are two things that are not clearly given. That is also important as well. So treatment, I'm not going to go into in detail, because that is not something that we are focusing upon here. It basically depends. Your cornerstone of treatment is always steroids. Depending on the weakness, you will gauge on your other additional modalities. So steroids is your main treatment course that alters the disease course as well as decrease morbidity, mortality. If you have just muscle weakness, that probably would be resolving trend, then you will start the child on 2 mg per kg prednisolone and then see, right? So if you see that the child is improving, obviously you will taper slowly. You will not taper across a month or so. You will taper slowly across 3 to 4 months. And if you see that there is almost complete improvement, you might as well not give any steroid sparing agent only. You might just give it 5 mg prednisolone and stop, not give any other steroid sparing agent. But however, if you see that the disease was severe at the outset itself and the patient has responded well, but there is some underlying muscle weakness, then you will give steroid sparing agents. For example, methotrexate is the usual first line steroid sparing agent that is given. Then you have IVIG. IVIG is usually given in severe muscle disease with something like a dysphagia, swallowing difficulty, because always remember, if the patient has dysphagia, the patient might aspirate, the child might aspirate, or with respiratory weakness, all of these severe muscle weakness cases, you will give IVIG. And over and above this, there are two main agents. One is rituximab. There are other agents also. There are cyclosporin, MMF, etc. We're not going to that detail. But two main agents. One is rituximab, which is given in refractory disease, and also HCQ, which is given, which is predominantly helpful for your skin disease. These are also two important drugs that are there. Then, yeah, this is what I was talking about, how the disease progresses. So prognosis is usually pretty good. So active symptoms, usually they last for around a year, and they either completely wean off. For example, 75 patients will have little to no residual activity. A lot of those will be after 7 years, but at least even after 1 year, they'll slowly stop to have disease activity. But 25% will continue to have chronic weakness. They'll require continued lifelong immunosuppression, while 40% have chronic rash, and 1/3 will need long-term medication to control their disease. So it's not like SLE, for instance. Childhood SLE will require lifelong treatment, at least with HCQ, low-dose prednisolone, etc. But JDM patients, a lot of them will not require any treatment after a good period of follow-up, for example, a few years, and then the child can be off treatment completely. So final question, the fifth question, fifth question, sorry, two JDM questions, one IgA vasculitis question was there, and there is one KD question as well. So yeah, something that we missed. yeah, so these 4 questions were there, and the 5th question is of KD, right? So Kawasaki disease, again, this was predominantly clinical feature based. Luckily, they didn't ask your coronary aneurysm screening, etc., because that was something that had recently changed. Your AHA guidelines had come, so that was not asked. I don't think that will be asked. That is a little bit too much in depth. But this was asked, that was fairly simple. Again, if you just treat clinical features, which is something that is very important for a general pediatrician, you could answer this. But again, they ask timelines, the timeline in which clinical features present in a Kawasaki disease patient. So that we will discuss. So this is your basic 5 manifestations. You have crash and burn, right? Burn stands for fever, high grade fever at around 101 degree Fahrenheit. It's some books it's written as 39 degrees Celsius, whatever it is. 101 is a better one to remember because it's given in your Nelson. Apart from fever, there is crash, right? So crash, C stands for conjunctivitis, bilateral non-exudative limbal sparing conjunctivitis. It is there. If you see, most of this will be non-exudative, non-suppurative. For example, even if this is non-exudative, even your cervical lymphadenopathy, adenopathy, A stands for adenopathy. That is also non-suppurative, unilateral, anterior triangle predominant cervical lymphadenopathy with lymph node size approximately more than equal to 1.5 centimeter. That is there. Then you have R. R stands for rash. So rash here can be any particular polymorphous rash, but here blistering or vesicular rash is not seen. Compare this with IgA vasculitis. Vesicular blistering rash can be seen, especially when there is a slightly higher age group. So polymorphous rash is there. Then you have SS first stands for strawberry tongue. Here you can have tongue redness, tongue erythema, increased papillae, as well as red cracked lips. These are your strawberry tongue manifestation, and your hand and foot erythema, edema. Initially, it will be erythema, edema, and later you will see peeling. That is also something that was asked. That is what, I think, yeah. So here it was not asked, but yeah, in some other exam, this was asked, that in which stage of the disease perineal peeling occurs versus periungual peeling occurs. That is also important, right? So there are 3 clinical phases: acute febrile phase, first 2 weeks, then you have subacute phase, following the acute phase for another around 2 weeks, and then you have convalescent phase. The main thing that defines convalescent phase is that inflammatory markers also return to normal, and slowly you will not require your echo screening. So you know that echo is done in Kawasaki disease because there is this risk of coronary artery aneurysm that is there. This is one side of things that is there, and then the other side is the most sinister complication, that is coronary artery aneurysm. So that you will do until convalescent phase is complete. So that is something that defines convalescent phase. Apart from that, the actual active phase is acute febrile versus subacute. In acute febrile, first 2 weeks you will have perineal desquamation, while in your subacute phase you will have periungual desquamation. If you're confused about this, because a lot of times in exam you forget, just remember that it is in alphabetical order, right? So N comes before U. So perineal desquamation comes first, then periungual desquamation comes. Apart from these crash, burn, coronary artery aneurysm, there are also 2 prominent findings. One is GI manifestations with vomiting, diarrhea, abdominal pain, up to 2/3 of patient that can occur, and respiratory manifestations. Again, non-specific prodromal manifestations like rhinorrhea, cough, etc. that can occur in 1/3 of the patients. So 2/3 GI, 1/3 respiratory manifestation, and there are some other important markers as well. One very important marker is your excess irritability, especially when age is less than 1 to 2 years. In the first 2 years of age group, excess irritability may probably due to aseptic meningitis, we exactly don't know. Excess irritability with not so much fever. There will be fever up to a certain degree, but it's not something that is persistent like meningitis, etc. So fever will last for 1 week, but excess irritability will last for a much longer time. That is something that can give you a clue that this is a possible Kawasaki disease and you should rule out. Then others are non-specific. Urethritis can occur, myotitis, sterile pyuria, arthritis, hepatitis, all of these can occur. So coming to these 5 main cardinal features, slightly discussing in detail because that is what was asked here. So fever is the most common manifestation. That is your sin qua non for diagnosis. High spiking fever more than 101 or 39 degrees Celsius or 101 Fahrenheit, and usually resolves within 2 days of appropriate therapy. Remember, appropriate. This is not antibiotic therapy. It doesn't resolve well with antibiotics. With appropriate therapy, that is your IVIG or sometimes just aspirin, it will resolve. Bulbar conjunctivitis, again, it is bulbar, limbal sparing, non-exudative bilateral conjunctivitis, and there can also be an associated mild uveitis. Polymorphous exanthem will be there, involving both trunk and extremities, and it will never be in the form of a vesicular rash, and it usually appears within 5 days of fever. Lips, oral cavity, we discussed strawberry tongue with prominent papillae, diffuse erythema of oral mucosa, cracking of lips, bleeding of lips, all of that can occur. Then cervical lymphadenopathy, unilateral, anterior cervical triangle predominant, firm, non-fluctuant, non-suppurative lymphadenopathy. Extremity changes, early phase of the disease, there will be more edema predominant. Late phase of the disease, there will be desquamation. Again, remember these images are important because images are being asked in your NEET assessment. So these are your other findings that are there. Obviously, cardiovascular findings cannot be ignored at all. It's basically, this is the only life-threatening thing, right? So if this is a patient who otherwise will just be looking like a viral illness, and a lot of times within 1 month it will resolve. But if this coronary artery aneurysm complication develops, then it will be a sinister complication, in the sense there is a high degree of acute ischemia that can occur, MI can occur in a childhood age group, and that is something that you should always screen and prevent. So apart from that, GI we discussed 2/3 of the cases, including gallbladder height drops, which is a good soft marker, good indicator. Respiratory findings more or less prodromal. CNS very important, especially in much younger age group, infantile age group, sterile urethritis, meatitis, sterile pyuria, all of that is there. So this is what was asked predominantly. If you see the question, fever, especially in acute, subacute, arthritis around subacute, around 1 to 2 weeks period. Then cardiovascular, initially it will be myocarditis, very initial phase when there is this hyperinflammatory stage, it will be myocarditis, later aneurysms develop in your subacute stage. Skin manifestations, initially perineal, later periungual desquamation, and when it comes to palms and soles, initially erythema edema, later desquamation. Lips conjunctiva in the acute phase, cervical lymphadenopathy acute, thrombocytosis predominantly after 1 week. Around after 1 week only thrombocytosis starts to happen. So these are your various lab manifestations. Two main things that you should remember are hyponatremia and hypoalbuminemia. This is usually asked in Viva, so that's why I'm focusing upon here. Thrombocytosis, I told you, and others, more or less, I told you. CSF pleocytosis, something that can mimic an aseptic meningitis, leukocytosis, all of that can occur. But two important things that are usually asked are hypoalbuminemia and hyponatremia. These are important. Elevated ESR CRP, you would obviously know. Leukocytosis, all of these are hyperinflammatory manifestations that are there. Eco findings, I'll post the in our group, in our WhatsApp group, I'll post the new screening guidelines. So so this is what is your basic thing, that is a diagnosis 2 to 3 weeks later, and then 6 to 8 weeks later when the convalescence period is ending. But it's not so simple. There are AHA guidelines where you basically, what you do is, at the outset you do echo, you see how big the diameter of the coronary artery is. So based on that, you will plan your screening period, when to do it, whether you have to do weekly, whether 2 weekly, etc., and up to what time you will do. So there's a big table that I'll post on the group, so that also you can go through. Maybe may not be asked in your NEET tests because it's slightly on the higher side, but because it's a new update that is there from the AHS, hence you can go through. So the main thing that is written in your eco report, when it's a good pointer that, okay, this is Kawasaki disease, is lack of tapering. Usually as the vessel goes from proximal to distal, there is tapering that occurs, right? The vessel becomes smaller and smaller. But if this tapering is not occurring, then that is what this area is, a aneurysm that has not tapered. So lack of normal tapering is a typical finding, and the coronary artery dimensions are adjusted. Z score is given. So based on Z score, if you see what is the definition for a giant coronary artery aneurysm. So giant coronary artery aneurysm has been asked in your INSS before in your pediatrics general. So giant, more than 8 mm internal diameter or more than 10. Z score more than 10 or more than 8 mm internal diameter. This is also important. It's not the whole diameter. Internal diameter 8 mm or more than 10. This you have to remember. Then features that suggest alternative diagnosis. So whenever we have seen suppuration, limbal involvement, all of that obviously is there. Vesicular rash, pustular rash. If lymphadenopathy is very much generalized, so here we saw that unilateral anterior cervical predominant is Kawasaki. If it is very much generalized, definitely we have to look for something like a malignancy, etc. Hepatosplenomegaly, not usually seen in Kawasaki. Transaminitis may be there, but hepatosplenomegaly almost not seen. Discrete oral lesions, it is a very generalized cracking that occurs, bleeding can occur, hemorrhagic exudates can occur, but discrete oral aphthous-like lesions are not seen in your Kawasaki disease. Tonsillar pharyngeal exudates, again look for infection. Exudative conjunctivitis not seen in Kawasaki. Coryza persistent. There can be cough, there can be rhinorrhea up to a certain extent, especially in your initial stages, but being persistent, then again that is something that where you have to keep a strong possibility of viral infection. So these are our various images, because your images are being asked to a large extent. So these are pulmonary conjunctivitis, hand foot changes, oral changes, aneurysm, polymorphous rash. These are your various images that are given in your Nelson, and especially those erythema, edema, desquamation, this being given in your perineal area, palmar area. These are images that can be definitely asked, and they can ask you the possible timeline. Why? Because this is what was given. The timeline based test question was there in your, this was a timeline based question, and also most of our text is also focusing on when what manifestation comes through the disease course. So it's a very important topic to be discussed, right? So these were your main questions that were there in your 2023 NEET assess, 4 questions only. So next session we'll go to endocrinology. That is one thing that has been asked a lot, especially your genetic syndromes have been asked a lot in your 2023 NEET assess. So we'll do that in the next session.